Good morning, everyone, and welcome to our workshop. My name is Hiba Jabarti from Patient Safety Center. You will be hearing a presentation from Dr. Khalid Zahrani, Dr. Ahmed Al-Sheikh, Dr. Mohammed Tawansi, and Dr. Mohammed Imam. They will be speaking to us about implementation of TeamSTEPPS and overview. Dr. Khalid Zahrani, he is the Deputy Program Director at Security Force Hospital in Mecca. He is a member of Patient Safety Center Consultancy Board, certified orthopedic surgeon by education and training, certified in medical education, University of Toronto. He has a certificate in patient safety and quality management from Royal College of Physicians and Surgeons of Canada. Also, you will hear from Dr. Mohammed Tawansi. Dr. Mohammed Tawansi is the patient safety supervisor at Security Force Hospital, Mecca. He is a medical doctor, researcher, and international speaker in quality and patient safety with an excellence entrepreneurial background in the healthcare industry. He earned many skills through starting to study quality and management before even finishing his medical study in 2009. Working in the first case manager team in Egypt, he worked as a deputy quality director in the largest GCI accredited military hospital in Egypt. His international medical center. Now he's gaining more knowledge and giving what he had learned through working in the Security Force Hospital program in Mecca, in Saudi Arabia, as a patient safety supervisor. He also worked as a presented in nationally and internationally through sessions, workshops, and posters. Also, we will have Dr. Mohammed Imam. He will speak to us also on the same workshop. He's the quality manager at Security Force Hospital in Mecca. He is healthcare risk management professional, expert trainer, coach, and international speaker. With a medical background as a physician, he has managed to achieve several professional certifications, including Total Quality Management Diploma, certified professional in healthcare quality, certified professional in healthcare risk management, and MPA in hospital management from the Arab Academy for Science, Technology, and Maritime Transport. Dr. Muhammad is also the holder of the TeamSTEPPS Master Trainer designation from the Agency of Healthcare Research and Quality, and he's designed and conducted several training courses and presented sessions at national and international conferences. Our last speaker will be Dr. Ahmed Al-Sheikh. Dr. Ahmed is the Quality and Patient Safety Director. He is Organizational Excellence and Development Acting Director of Security Force Hospital in Mecca. Dr. Al-Sheikh is the Director, Surveyor, Trainer, Instructor, Author, and International Speaker in Healthcare Management with a live mission to treat healthcare. With experience in healthcare management, quality, patient safety, risk, and excellency, he participated in several national policymaking and international healthcare projects. His performance measurements and innovations in improvement work were recognized several times on regional and international levels. He also presented numerous keynotes, workshops, and sessions across the globe. The participants, let's welcome Dr. Khalid to start the presentation. But I want to just highlight one thing that kindly notice that the question will be at the end of each part of our speaker. So you can write your Q&A questions in the Q&A icons or in the chat, and our speakers will gladly answer them. Dr. Khalid, the floor is yours.
Thank you very much, Hiba. Assalamu alaikum wa rahmatullah. Good morning, everyone. Let me load my presentation first. Okay, the share is not showing from my side here, but can you help me with this? Share icon. It disappeared.
Sure, doctor.
Can you share it from your side, Ahmed?
Sure, doctor.
Assalamu alaikum wa rahmatullah. Good morning, everyone. So thank you, Hiba, for this nice introduction. And I'm very happy and glad to be with the Saudi Patient Safety Center and WHO in this educational activity. What we will talk today is about a highlight and overview about the TeamSTEPPS. And as all of you know, that TeamSTEPPS is one of the tools that is very supportive, and we discovered this like 8 or 9 years ago, that this will be one of the best tools that we can utilize in our hospital to improve our performance and do a better care for our patient and end up with protecting our patient safety. Next slide, please. So TeamSTEPPS is a tool that can be utilized in every hospital. It's customizable, it is flexible, and you can use it. And in our hospital, we are locating in Mecca city, and we are covering a wide range of area, which is the western and northern and southern area of Saudi Arabia. Our hospital is a specialized hospital that serves hundreds of thousands of population and providing care to our patient, our client from this big region. And also based on our location in Mecca, we are serving an important sector of population, which is those visitors to Holy Mecca during Umrah season and Hajj season. Our hospital vision is to be a leading and recognized hospital in healthcare that will be providing a better care for our patient, and it will be first choice for our clients. So, as introduction for the TeamSTEPPS here, we will just look as a highlight in this part of the presentation and give you an overview. What is TeamSTEPPS and why it is important and how can we use it? Then after that, we'll go to the details of these tools and move forward to know more about the implementation and how can TeamSTEPPS help us to improve our performance. And when we look to the importance of the TeamSTEPPS, and we should look to the importance of patient safety. So based on many reports, it was discovered that patient safety is very important to our healthcare, and there is lots of errors that cause death and damages to our patient throughout their journey in hospitals. This report was released in 1999, and it shows that about 44,000 to 98,000 patients died in the hospital during hospitalization, and this number raise a red flag that there must be an actions to protect those patients. If you compare this rate of death to other causes of death like annual death from car crashes, it's double number. If you compare it to other death from other diseases like breast cancer or other diseases, like tripled the number. So it's very important here to consider that there is a risk in our hospital. We are working in a very dynamic and very dangerous situation where we are handling a serious patient. And if we are not working collaboratively as a team in our institution, this might lead to a significant errors that reach patient and cause harm to our patient. One of the most important things that we should consider is working as a team. And I would like to raise the first question here. What are the causes or the reason or the barriers to work as a team in a hospital institution? There are many, many reasons that you can consider. Importantly is the communication between the healthcare provider, realizing the team, who are the team. If you take the patient journey when he started to visit the outpatient or emergency room, he presented through a complex process that's starting from seeing the patient in emergency, and he will go through a sequence of process starting from initial assessment, then evaluation and assessment, then after that he will go through a process of diagnostics procedures, whether clinical or utilizing images or laboratory tested. And after that, we'll decide what we will do for the patient to be treated, and then he will receive the treatment. So this process, if you look at it, there are many people in the hospital dealing and handling patients, starting from nurses, pharmacists, physicians, even other supportive people like the administrative team and registration and the housekeeping and the maintenance. All those people are working in one area, and we consider them as a team. So if there is inconsistency in the team membership and the team is not working in a harmony, this will be a barrier that can block or cause an error to reach patient throughout this process. If the people sometimes said we don't have time to work as a team, some of them, they are lacking information or training about how can they communicate properly. Sometimes people are looking to the hierarchy, so maybe nurses facing some challenges to communicate with a consultant physician or with senior physician, and these kind of things could hinder the process and could cause a significant error to the patient. Conventional thinking of way that I'm handling the patient in my way and I don't care about the others, what they will do. This is a serious thing, because managing patients in a healthcare institution is a team process. It is not a personal process that one person can handle everything and can treat patients. So looking to this from a different perspective will help you to realize that working in a team will help you to work in a safe environment and providing a safe care for your patient. Sometimes there is a conflict or lack of coordination between the team. These kind of thing also can work as a barrier to provide a better care for the patient. Other barriers like distraction, fatigue, workload, and these kind of things could help. So here we will try to utilize the TeamSTEPPS as a tool that will help us all to improve our performance, to provide a better care for our patient. Can I move to the next slide, please? So what is TeamSTEPPS? TeamSTEPPS is a structural way that you can utilize to improve patient care and to provide a better care for your patient. So if you are looking to the TeamSTEPPS structure, you will find it based on how can we provide a better care for the patient, and this better care can be delivered if we have a proper leadership to our patient, and if we have a good communication between our team, and we have a proper assessment and situational assessment for our patient. This will help us all to improve our skills, and this will improve our knowledge, skills, and attitude, aiming to deliver a better care to the patient. So TeamSTEPPS stands for strategies and tools So it is a strategies that you can use in your daily practice. And tool, we will just give you a hint about it and how can you utilize it. There are many different tools that you can implement it. And these tools and the strategy will help you to enhance your performance, enhance the team performance, and this will help us, if we have a better performance, to provide a better patient safety for our patient and better outcome in our healthcare institution. Next slide, please. So again, this triangle, you will see it a lot today, and we'll discuss many things about it. So if you see the core concept or the core competencies that we would like to deliver and give you an overview about it, it's about how can you be a better communicator in your healthcare, how can you improve your communication, and we'll give you some tools to help you to deliver or to communicate in a better way, and how can you have a mutual support within the team. So the team composed of a team members that each one of them will work collaboratively to improve the patient care and to deliver a safe practice to our patient. And this team or mutual support will be based on a proper leadership. Leadership is important here because those who is leading the team and managing the team will help them to get in a harmonic way to have a better communication and smooth performance. And proper situational analysis is essential skill and concept that you will learn. This concept or four corner concept will help you, if you learn it, to improve your knowledge, skills, and attitude. So these skills, if you deliver it and provide it to your team and improve it within your situation, will help your knowledge to be better so you can deal with your patient in a better way, and will help you to do things in a good way and do it in a very smooth way with your team to improve patient care and deliver better care to your patient, aiming to provide a safe patient care. So looking to the summary of the tools here, and this is what we will discuss throughout this webinar, we talk about the barrier. So first, we should know or be aware that there are some barriers. And we discuss these barriers and we explain it very well. And this barrier, once you realize it and help your team to realize it, will help everyone to reflect about it and try to improve how can he do better and to overcome these barriers. If you be aware and realize these barriers, you can consider how can you overcome it using the tools that we will discuss in the TeamSTEPPS workshop today, like how can we improve our communication using SPAR, call out, check back, and hand off. These concepts are very important to understand and realize because it will help us all to improve our team performance and deliver a better patient care, aiming for better outcome. So once we implement it in our practice, we practice it, this will help us to have a shared mental model that will help us to provide a better care to our patient. It will, if you adapt it within your teams, within your department, within your performance, throughout the journey of the patient, this will help you to make it as automated in your practice, and this will help you to improve your team performance and team outcome. So in our hospital, we started to use the TeamSTEPPS tools in 2016. We started many training process, and improvement project was built up based on the TeamSTEPPS concept and tool we implemented in many departments in the hospital. And we were successful in achieving many good outcomes based on the tools that we implemented. For example, in clinical units, in our hospital, SPAR, which is based on four steps to start by situational assessment and background check and assessment of the patient in a proper way, and ending with a recommendation. So using SPAR help us to improve the adverse drug event from 30, reduce it from 30 to 18 per 1,000 patient day. And this was a big achievement. Again, it helped us to improve medication reconciliation within the hospital from 70% of our patients in admitted patients to 88%. And we are looking for 100%. And it also helped us to improve our medication reconciliation for discharged patients from 53 patients to 89 patients. So simple tool, help you to do a lot utilizing this tool and building up this concept within your team. Another example, in operating theater, we use the pre-op brief. And in summary, the pre-op brief is that the team will gather, all the team working in OR, treating the patient will gather before starting the day, and they will review all cases and they will reflect about it, and they will discuss what they will do and discuss if there is any challenges and how can they overcome it. It will take like 15 to 20 minutes maximum. And this will help everyone in the team, including the nurses, scrub nurses, circulating nurses, physicians, surgeon, anesthesia technician, and everyone working to serve patients in OR to be aware what they will do and to be aware if there will be any challenges in that day. And the pre-op brief help us to improve our performance in the operating theater. Yes, so improvement in the, for example, here, this is some example that we improved the proper timing of prophylactic antibiotic from 84% to reach 90%. And I think in the last report, it's almost reached 100%. And we improved the VTE prevention or prophylaxis from 92% to 100% in those patients. And we increased the satisfaction of the OR team by 19% and reduced turnover by 16%. So these tools, which is simple one, very helpful to improve your performance in any department if you utilize it. For example, in labor and delivery, we have 50% reduction in weighted adverse outcome score, and we have 50% reduction in the severity index, utilizing TeamSTEPPS tool and communication, better communication between the team within the hospital. Another example is here, medication error using SPAR, which mainly used by the nurses and help the nurses to communicate properly with the physician and with the pharmacist. It helped us to reduce the medication error from 25 to 3 per 1,000 patient day. So you can see that these tools are simple. Once you realize it's important, train your team on it, and it will help you to improve the outcome of your patient and the performance of the team. These are many other examples that we are implementing in our hospital. Generally, what we are doing, we are trying to implement different type of tool based on the need in different departments. If you look to this slide, you will find that our patient safety culture is improving over years. So as you know, patient safety culture survey is a validated tool that will help you to measure the patient culture safety within your institution. Now the Patient Safety Center is trying to generalize it to be implemented in every hospital. When we started in 2015, our score was 50%, 57%, and we get improved to reach 89% in 2022. And hopefully the result of this year will be better, and we are looking forward to see the result of this survey for 2023 soon. So this is a measurement or validated tool that showed that our patient safety culture improved within Security Forces Hospital over years based on implementing the TeamSTEPPS principles and utilizing the tool of the TeamSTEPPS. So why TeamSTEPPS is different? Why it is different from other tools that you can use? So there are many things, many factors. So TeamSTEPPS is a tool that is worldwide used in many institutions, in many hospitals. We believe in it because we find that it is useful to our team, it's useful to our patient, it helps us to improve our performance. And this tool actually was developed and based on evidence-based criteria from the field. It was tested and validated, and many institutions found its value. So this is why TeamSTEPPS is different from other tools. It's comprehensive, so it's covering many area or competencies that will help your team to improve their performance, and it's customizable. So as I demonstrated, you can implement it in ER, outpatient, inpatient, OR, in any area in your hospital. This customizable tool, you can select from this toolbox whatever tool that can help you to improve your performance based on the service you are implementing this tool in it. So it's customizable, it's comprehensive, and it's easy to use. It's not so complex. And you will find in the coming part of this webinar that there are many tools, and you can implement it in different way based on the different need. It's publicly available and it's free. So it is a free tool that you can use it and implement it within your hospital. So this is an overview I presented about the TeamSTEPPS, and in the coming parts we'll discuss more about the details of this tool, what kind of tool we can use, how can we structure our team, and how can we improve our performance. At this point, I will forward the mic to Dr. Ahmed Al-Sheikh if there is any question, or we come to the next part.
Thank you so much, Dr. Khalid. I hope that the voice is okay. And we have so far almost 260 attendees, which is great that we have all these healthcare professionals who would like to improve the team communication and team strategies, which inshallah will hopefully today is going to help them. Thank you for the introduction about the TeamSTEPPS and how it helped us in Security Force Hospital Mecca to improve the services. I see no questions related to the knowledge so far. Inshallah, by time we're going to collect more questions, and we highly encourage you to ask. This is a dynamic two ways workshop. Please put your questions in the chat or in the Q&A. We have a panel discussion by end of the session, but if you have any questions during this session, you can definitely throw it and we will be happy to answer. Now we will move to, thank you so much, Dr. Khalid. Now we will move to our second speaker, Dr. Mohammed Tawansi, which will start to build the first blocks of TeamSTEPPS, starting with the team structure and moving to the communication. Afterwards, we're going to have a short break for 15 minutes. Then we will continue our journey with TeamSTEPPS for today. My pleasure to introduce Dr. Tawansi.
Hello, everyone. First of all, I'd like to thank the Saudi Patient Safety Center for preparing this amazing gathering. actually, and I'd like to thank you coming from many different countries all over the world in order to learn and to exchange knowledge between us and you. Uh, I'd like to thank Dr. Khalid Al-Zahrani for his amazing introduction and Dr. Ahmed Sheikh for moderation. Now, inshallah, we are going to talk about team structure as the first component of the Team Steps initiative. So after ending this module, inshallah, you will learn and discuss benefits of teamwork and team structure. And we will know how to define a team. And also we will identify what are the roles of the patient and their families as part of the care team. Also, we will describe the components and what is the meaning of the multi-team system in the healthcare setting, and what are the components of it, and who are the real members of the multi-team system. So this is a simple math. Simple math is 1 plus 1 equals 2. What about working as a team? What about working in synergism? What about working in harmony? This will make 1 plus 1 is more than 2. This is team synergy. So what is the difference between the group and the team? Actually, the group is a gathering of people, like people attending a lecture or something like that. Each one has his own goal and their own aim. Some people want only the same me, some people want to learn, some people want both. Okay, but they are working independently. Each one has individual goal, and there is also no shared responsibility. While in a team, there is a common goal. They are all working collaboratively in order to achieve this goal. They have shared responsibility, and also they are interdependent. So they should work with each other in a common and one goal, and also one plan. So a team is greater than the sum of its parts. So regarding the team structure, so we should know that the teamwork cannot occur in the absence of a clearly defined team. So each one of the team should know clearly his or her roles and responsibilities, and should understand the team structure and how multiple teams can work to and interact, especially in some situations and especially in critical situations. And that's what we are going to know. So now we are building the base to know what is the team inside the healthcare setting. So how can we define a team? So the team is different, as we just discussed, different than a group. It's two or more people, but they work dynamically, interdependently, and adaptively towards a common goal and valued goal. And they have specific rules or functions, and have time limited membership. So these are some characters of the team members, because it can include anyone involved in the process of patient care, and including the leader for sure. The leader is one of the team members. They should have clearly defined rules and responsibilities, and also they are responsible and accountable to the team for their actions, and they must stay continually informed for the effective team functioning. These are the stages of the team development, and also mainly this work in what we will call the core teams. Yeah, for example, the first step is the forming. The forming is the first part of formulating a team, establishing the ground rules and preserving the formalities between the team members. After that, the members communicate and maintain strict individuality. This is what we call storming. And after the storming, what happens after discussions? Some kind of team bonding and the higher acceptance of perspectives. This is what we call norming. Performing is less emphasis on hierarchy and more on flexibility, more on discussions, more on ideas, more or we get used to each other's. While adjourning is the yearly assessment and plan for acknowledging individual contributions. So please answer me. As you can see, these are some members of the care team: doctors, nurses, security, laboratory, radiology, administrative. Who else can you see is missing here in this figure? Please, you can answer using the chat. So now we can find that the missing is, yes, the patient. The patient is very, very important member of the healthcare team. We are all working to give a high quality healthcare service to the patient. So that's what we are calling patient-centered care. The care should involve and engage the patient even in the decisions. We should consider the patient preferences to a limit, and also we should discuss the decisions with the patient. The previous Patient Safety Day this year, it was the main theme for this day was engaging patients for patient safety. And we believe that many hospitals, also our hospital, participated in this day by raising the awareness and elevating the voice for patients. So what do you think? How can we partner with our patients? What are the steps or what are the ideas to increase the engagement and partnership with our patients? Here are some strategies and ways to involve patients in their care. We can include patients in the bedside rounds. We can provide them with some tools of communicating with their care team, also to conduct our handoffs in the bedside, at the bedside, and involve them in the key committees, and also actively enlist the patient participation. One of the initiatives from the Joint Commission is the Speak Up, to involve the patients to speak up, especially diabetic patients. These are 5 ways to be active in your care at the hospital. This encourages diabetic patients to participate in their care. Also, another initiative by the IHI is Ask Me 3. So this educate our patients to ask 3 main questions. What is my main problem? What do I need to do? What is why it's important for me to do this? This active participation, as we will see later, it will help to improve the care introduced to the patient and reduce any kind of errors that might happen. So as we talked at the start of the session about the multi-team system for patient care. So in a healthcare settings, there is not only one type of teams that is working. It's not like a football game. Even in football, there are many teams. But in a healthcare setting, it's more dangerous. We are dealing with humans. We are dealing with lives of people. So the first, this diagram shows the multiple types of teams: the core team, contingency team, coordinating team, ancillary and support services, administration, and don't forget to include the patient as one of the teams. So what is the core team? The core team is These are introducing the direct care for the patient from starting from the point of assessment to the point of disposition. This is the first line. These are dealing directly with the patient. This is the core team. These are the physicians, the nurses who are dealing directly with the patient. What is the contingency team? Contingency team is a time-limited team. In some situations, we need some people from different teams in order to work. These are kind of emergency situations, like the code blue, like the disaster, like the RRT, and so on. So in this case, we can take a physician, nurse, anesthesia. You might need maybe a patient relation to be in the team, and so you will gather many people from different teams. This is a temporary team and not following the case of the patient from time to from time of admission to time of discharge, because this is an emergent situation. This is the contingency team. So the coordinating team, this is comprising those who are responsible for managing the operational environment that supports the core team. So they might include the housekeeping, the CSSD. So their work is very important, supporting our work. And without them, we cannot do our work in a professional or high quality way. Ancillary and support services. These include our colleagues in laboratory, radiology, and these settings, because and pharmacy for sure. The support services provide indirect service focused tasks that help to facilitate the optimal healthcare experience for patients and their families. And also the administration. So the administration don't participate directly in the patient care, but they have the overview, they have the planning, they have the support and encouraging to the staff during the implementation of the, and also they apply the culture change strategies, and they hold the teams accountable for team performance. So this is for now the end of the first module talking about the team's structure. We will receive questions. If you have questions, then we will continue to the second module, which is the communication. Do you have any questions? Patient involvement in decision making. Excellent. Thank you. Thanks for your participation. This gives the session a dynamic feeling. Okay, patient. Okay. Okay. Do you have any question, or we shall continue to our next session? Okay. Communication. So now, after we discussed the types of teams and the multi-team system in healthcare settings, what are the teams, what are the types of teams? Now we need to communicate between these teams. We need to enhance the communication and know some tools and strategies in order to enhance this communication. So after this module, you will describe how communication affects the team processes and outcomes. You will also be able to define effective communication. You will identify what are the communication challenges and barriers, and how can we use the TeamSTEPPS tools to overcome it. So effective communication skills are very vital for patient safety, and the communication is considered the linchpin that holds all the TeamSTEPPS modules with each other, because leadership communication with the team needs to enhance communication. The mutual support needs communication skills. The situational monitoring needs communication skills, and this also holds the team structure and team members with each other. So this is the mode by which most of the TeamSTEPPS strategies and tools are executed. So, as per the Joint Commission, the ineffective communications caused 66% of all reported sentinel events. It was the root cause of this. And also, it was among the top 3 root causes of sentinel events reported from 2010 to 2013. So, what's communication? Communication is the process by which information is exchanged between individuals, departments, or organizations. So it's effective when it permeates every aspect of an organization. And as you know, communication has great effect on our lives, even in our work, even in our personal life. So, what do you think is missing here? We have a provider, we have a receiver. So, what's missing here? We have the input. Is it final? Do you agree about this? Is there anything missing in the diagram? What do you think is missing in this diagram? Way of communication. Feedback. Excellent, excellent, excellent. Feedback. Thank you. So the missing here is the feedback. That's what we are calling the closed loop communication. So we give an input or a message, and we should receive feedback. Most of the problems happening in causing errors to the patient, and even most of the problems happening in real life, is not getting the feedback. I'm giving messages, I'm not getting feedback. So, as per regarding the face-to-face communication, the meanings received more, although sometimes we think that words take the largest part in communication. Actually, not the words, it's the body movements, the face, the arms. Then after that, the voice tone. How do you use the pauses in your talk? And lastly are the words. So there are some kinds of non-verbal communications. These non-verbal communications is like the charts that you are displaying in your presentations, the colored scripts, the use of color coding for assignments, and so on. These are kind of non-verbal communications. So an example of difference using the tone and what is different in the meaning that reaches my mind when these words are said to me in different tones. Here we have the same sentence, but we can say it in different ways. we can say, I know who mixed the files. Or we can say, I know who mixed the files, pointing to someone. The first one have some kind of ego. And I am pointing to myself. While the second one, I am pointing to or accusing someone of mixing the files. So the tone is giving some kind of difference in the meaning that is reaching the audience. Here also another one, we can say, let's eat kids, or let's eat kids. So what do you think is the difference between both? Please reply to me in the chat. So the first one seems like we will eat the kids, actually. While the second one, I'm saying to my kids, let's eat kids. So also the pause is different, and the pause can give a different meaning. So our standards of effective communication, my communication should be complete. I should deliver all the necessary and relevant information, and also to give time for questions. My communication should be clear to convey information, and also the information that I'm giving should be plainly understood. I cannot talk to my patient using medical terms. He or she will not understand me. I should use simple terms. Also, my communication should be brief, should be not high level of words and many words, so much words. It should be brief and to the point. My communication should be timely. I should offer and request information in an appropriate time frame, and also use the exact time and correct time to give the information. So an example of the complete, in order to ensure that I am delivering complete information, I can ask, do you have any questions? Or ask me questions if you have. Brief, all and only what you want. Clear how X is X. And timely from receiver perspective, not only from my perspective. Now, please answer me. Is this communication clear? What do you think? Thank you, Dr. Shayma. No, not clear. Thank you. Is this communication brief? Really, it's brief? Dr. Khan, do you think this communication is brief? I think people will jump before reading it. Thank you. Do you think this communication is timely? Also, Dr. Khan saying yes. This communication is not timely because he is putting the warning after the penguins are already in the water. So it's not timely at all. Okay. Thank you, Dr. Shema. Thank you, Dr. Amira. Okay. So do you think this communication is complete? Why? Why no? Why it's not complete? Yes, E, because it's missing the E. Okay. So what do you think? Please answer me from your point of view. What do you think are the communication challenges or barriers? What are the barriers for communication? I think you can remember it. Hierarchy, right? Language. Thank you. Thank you. Ego. Clear. Communication. Fear. Clarity. Language. Lack of sharing. Language. Amazing. Use of jargons. Thank you. Lack of time. Culture differences. Low literacy. Fatigue. Respect. Yeah. Workload. Excellent. Thank you. As you said, language barrier, distractions, also physical proximity, personalities, all of this you mentioned. Workload and varying communication styles. Conflict in personalities, hesitation, confidence, pressure, workload, shortcuts, lack of information verification during shift changes. Okay, so here we have some strategies to overcome these barriers. They are kind of tools, strategies. You can call it as what you want. The first one is the S bar, then the call out, the check back, and the hands off. The S bar, I think most of us, did you hear about the S bar before? For sure. Many of us heard about S bar. S bar is a technique, not only a tool. So a technique of delivering the necessary information. So the S states for situation. What's the situation of the patient? The B for background. What's the background of the patients? What are the previous history of the patient? The assessment. What is the problem? The current problem. Do we have any kind of investigations? Important investigation that need to be delivered to the one who you are delivering this information. Recommendation also, this is what do I recommend and what are the requests to be done for this patient. So what about the call out? The call out actually is used to communicate critical or important information. So it informs all the team members simultaneously during emergency situations, and it helps team members to anticipate the next steps. And this is the third tool is the check back. As we just talked about the closed loop communication. So the sender initiates a message, the receiver accepts message and provides feedback confirmation, then the sender verifies message was received. And this is very important during our communication in healthcare. So you are, for example, asking for a certain investigation to be done to the patient or delivering a critical value of a result for the patient. The nurse who is hearing you should confirm the result and read back the result to you, and then you confirm the result with her. I think we do this when we order from any kind of delivery restaurants or something like this, and we should the one who is receiving our order is reading back to us our order, and this there is any difference or discrepancy, we should correct it. What are the hands off? So the hands off is the transfer of information during transition in care across the continuum, and includes an opportunity to ask questions, clarify, and confirm. It consists of transferring of responsibility and accountability, and it should convey clarity of information, verbal communication of information, and the information received should be acknowledged by the receiver. And also we should give opportunity to review and ask questions. Like, do you have any questions? Thank you. So what do you think? Code Blue, consultation, phone order, shift change. Which of these is using call out, S bar, check back? What do you think? Code Blue is using what? Do you think it's using S bar, call out, check back, or hands off? Code Blue call out. Thank you. Excellent. Miss Fadwa, Dr. Fadwa. S bar. Code Blue is not using S bar. S bar is used to deliver information during, like in shift changes or something, not in an emergent situation. In an emergent situation, we need to use the call out because it delivers critical and the most important information. So what do you think about the consultation? Which tool is it using? Consultation, S bar, check back, S bar, check back. Actually, it can use both, by the way. So in consultation, the consultation needs to be delivered. The one who I'm consulting, I need to use S bar, and he also we need to use the check back in order to confirm the information. Regarding the phone order, what do you think? Which one we are using? Check back. Thank you. Check back. Okay, or read back. Thank you. Excellent. Regarding the shifted change, hands off, S bar, hands off, S bar, both. We are using both. And also we can use the, for sure, we use also the check back. So we are using here 3 tools in the shifted change. Okay. So far now we discussed some barriers, as you can see, and we use some tools in the communication. We use the S bar, the call out, the check back, and the hands off in order to, and we will continue for sure to learn some modules in order to achieve our outcomes of shared mental model and to be adaptable and to have team orientation, mutual trust, team performance, and to improve our patient safety. So do you have any questions, please? Do you have any questions before we have a break for 10 minutes? Then you can come back. Thank you. You want a break 10 minutes or 15? 15, 10. We have 1:15 and 2:10. So we'll make it 13. Inshallah, no break. No, it will be hard for, it might be suitable for some, but hard for others. So we will take a break for 10 minutes. Okay. Inshallah, 10 minutes. Then we will return back to you with Dr. Muhammad Imam. I'm very happy and delighted that I introduce these sessions with you, and also to join Dr. Khalid, Dr. Ahmed, and Dr. Imam, and to join the Saudi Patient Safety Center. Okay. Thank you so much.
Okay, she currently
Assalamu alaikum, everyone. Uh, Welcome back. Okay, so I'm Dr. Muhammad Imam, the quality manager in Security Forces Hostel Mecca. It's a pleasure to be with all of you today, and a pleasure to join again our Saudi Patient Safety Center in its always leading presentations and in collaboration with the WHO. So I'd welcome you back all to this presentation. Today I'll be with you in two sessions in leading teams and in situation monitoring. As you have seen in the previous few sessions, we have discussed the structure of the team, which will be responsible for the patient care, how to create this structure, how to communicate properly within the team members. And now we'll discuss leadership and what are the traits of leadership that are important to maintain a safe patient care environment for our patients. Um, uh, I'd like just first to set your expectations. Leadership for most of you, or almost all of you, it's not a new concept. You are all performing some sort of leadership roles or traits within your family, within your friends, within your work environment or learning environment, or if you're still learning. Our main aim here is to put some structure to this very important trait that's very important to be in every one of the team, of the patient care team. So leadership is a very important aspect. Today we'll be learning about how leadership affects team processes and outcomes. We'll learn to identify different types of team leaders, describe the activities involved in successfully leading teams, describe the tools for leading teams, including briefs, huddles, and debriefs, and how to use these tools and when to implement them, and apply these tools for leading teams to specific clinical scenarios. The Leadership Center defines leadership as a process whereby an individual organizes and influences a group of individuals to achieve a common goal. Leaders influence their teams by facilitating the team actions, ensuring that these teams have the necessary resources to implement the plan you want them to implement and to reach their goals, ensuring that the roles and tasks are understood, clearly communicated. You should be always monitoring that these goals are well understood by the team members, and you can change the course according to this understanding, and being knowledgeable of the team members' skills and expertise so that you can assign each team member to the role that is more suitable to his or her skills and expertise. This is in addition to creating a climate in which this team can perform their tasks properly by establishing a clear plan of care, identifying the roles and responsibilities of each team member, developing the norms within which the team can operate, and communicate the plan to all team members. Then monitoring the plan of care and the surrounding situation to better anticipate patients' needs, effectively managing the resources to meet those needs, and adjusting the plan when necessary. Then you yourself should be able to model these behaviors, because the team will not follow into your plan if you yourself you're not modeling these behaviors for them. And you should also reinforce and reward the appropriate behavior so that it's continuously improved and enhanced within your team members. Team members can be either designated or situational. So designated team members this is a designated leader is the person assigned to lead and organize a team, establish clear goals, and facilitate open communication and teamwork among team members. Situational leaders are any member of the team members who has the skills to manage a specific situation in which the team is. So if you can join me in this presentation, I'd like to get your feedback. Can you give examples of designated team leaders versus situational team leaders? Kindly use the chat to submit your answers. So again, designated is an assigned leader, okay? Situational, okay, in which a situation that mandates a specific person to be a leader. Very good. Exactly. Situational is like code leaders. What else? Code blue, yes. So you're mainly going very good. Designated is like a department leader. Excellent example. Very good. Head of department, yes, very good. All very good examples. So you get the concept. So designated is a person who is already assigned as a leader. Situational, like any leader who is assigned in a crisis mode, in a code, in any situation that mandate in an RCA, very good example. In an RCA, these are all very good examples. Okay. Moving on to effective leadership traits. So the first step of leading a team is establishing some rules of engagement under which the team members will operate and perform their roles. So you set the rules of communication, the rules of performance, the rules of reporting. All these are rules of engagement in a specific task. So if I'm doing this on a situational basis in a crisis mode, this means that this rules of engagement is preset. So it's preset. You are trained to perform under this crisis situation so that once the situation or the code or the crisis is in hand, you can quickly adapt to the situation and implement all these traits that you have been trained on. You should also be able to manage and allocate resources, make sure that all items required are there, the specialities you need in this teams are available, the equipment is ready and functional. All this are considered resources that will help you manage the situation effectively and safely. You should also provide continuous feedback so that you can progress towards the goal. If you notice that one of the team members is not on board, performance is not meeting your requirements, you should continuously be able to provide them with feedback so that they can set their aim back to the shared goal. Facilitate information sharing among the team members, and again setting a good climate for this sharing. We'll talk further about this later on. Encouraging your team members to assist one another. You yourself should again be able to model all this traits that we were talking about between the teams, and finally facilitate any conflicts that might occur between the team members and resolve it as quickly as possible. So as a step-by-step approach, we start by defining a clear plan for the team members. We assign the tasks and responsibilities according to the team members' expertise. You share this plan with the team using some effective leadership tools like the briefing, the huddles, and debriefing. You continuously monitor the progress towards the goal. You resolve conflicts as quickly as possible, and you promote and model teamwork for your team leaders. So we'll shed some light on some of these aspects, starting by defining the plan. So when developing a plan, team leaders should consider the time in which the task should be implemented or the goal achieved, the people, the expertise of the team members, their level of knowledge, their skills, the equipment again, and if it's necessary, the necessary equipment is available or not, and the availability of information to all team members. And if all information is present, sometimes you need to collect some information to be able to manage a crisis situation properly. Then assigning tasks by determining the tasks and roles to be assigned, determining the roles that must be filled, and allocate the tasks appropriately. Communicate clear expectations of what team members need to do, and request feedback whenever it's required. So now we'll go to the leadership tools we were talking about: the briefs, the huddles, and the debriefs. So briefs are usually at the beginning of a situation. Okay, it's used to share the plan, assign the tasks during this briefs, make sure that everyone has some sort of a shared understanding of the task at hand. Then during implementation of the tasks itself, or during resolution of the situation at hand, you can perform some huddles. This huddles helps your team to gather back and discuss what's going on during the task. Are we heading properly towards our required goals or not? So this is used more for problem solving. And after each situation, you should go to a debrief in which you review the team's performance. This can help you to further improve in future situations. So we'll share with you a brief video, a less than 1 minute video, showing you how the briefs are implemented in a labor room before an operation. The leader will be discussing the plan with his teams, and you can see how he models this. First of all, shares this understanding with the team members, and helps them by promoting the required behavior to achieve the goal.
Okay, she currently only has intermittent late decelerations, and these have improved with her position changes and supplemental oxygen. We'll monitor her until she's fully dilated and allow her to push. If there's any evidence of fetal distress or persistent late decelerations, we should be prepared to go to C-section.
I've alerted the OR to be prepared in case we need to use it.
Great. I'll discuss this plan with Mrs. Keys when we're done here. What are her vitals right now?
Normal, just checked 15 minutes ago.
She's had no late deceleration since you recall.
Let's continue to monitor her. I need to know when she's complete and pushing so we can keep a close eye on her second stage. Any questions?
He wants to induce labor with.
Okay, so you have seen how the team leader explained his plan to the team members, what to expect during this operation, during this situation, what to do if an urgent situation arises. He's trying to clarify all the whole process, try to eliminate any surprises. And at the end of the meeting, he allowed them to ask questions and clarify if all team members are on board. So since this is our first video, I'd just like to confirm that all of you had heard the voice clearly. If you can write in the chat. Did you hear the video clearly? Okay, very good. So everyone had heard it clearly. So this is an example of you using briefs in a clinical situation. Some examples of using briefing as a tool in leadership is what we do during the timeout. You know that the WHO has set clear standards for safe surgical practice, the universal protocol, in which there is time out, sign in, and sign out. During the time out, you get to clarify the team members the roles and responsibilities of each, what is the goal of our operation, recheck the identity of the patient, and all this information that you're all used to. So can you name me a few other examples in which briefs can be utilized? Okay, very good. We have some very good examples here. During briefing before drills, excellent examples. Before managing critical cases, yes, before managing any critical or clinical situation. Discharge plan, excellent example, discharge planning before planning for patient discharge. A briefing session, a multidisciplinary briefing session would be excellent. Code blue, excellent examples. Okay, very nice. You can use it also during any emergency response, during handovers between shifts. Very good, excellent examples. Okay. So also for the huddles, again, so huddles is implemented during the implementation of a specific task or handling of a specific situation. You can use it to just return back to the team members, provide them with feedback, make sure that everyone is reoriented with any new information. For example, you're helping all your team members to have a situational awareness about the goals of this situation and the outcomes required. We'll again show you a brief video on the implementation of huddles.
Yeah, here's his electrocardiogram.
Oh, this looks like it could be an acute MI. All right, everybody, hey, let's huddle up before we go in so we know what we need to do.
Well, I've got the 4 liters O2 by nasal cannula and 2 aspirins. He's hypotensive, so we might want to drop the nitro. He's already on the monitor.
Good catch, Karen. Hold the nitro. Where are his cardiac labs?
His labs are pending. We should have those in 15 minutes.
Okay, let's prepare to get him to the cath lab immediately.
I'll call the cath lab to confirm.
Okay, all right, let's get in there.
Okay, so as you can see, they're all practices that are almost most of you are doing it on daily basis. We're trying to show you that by putting a structure to these practices, you can do it more effectively. So as you have seen, he used this huddle to again make sure that all team are sharing a standard or a unified understanding of the situation, informing them of any new emerging events or new requests, and making sure that they are all heading to the same outcome and to the same goal. So don't leave gold on the ground. With our final tool, the debriefs. Okay, so after each activity and after each situation, there are always room for learning from this situation. You will never achieve a perfect performance from the first trial, but the only way to improve upon this first trial and to learn from these lessons is to make sure that you are performing a continuous practice, a standardized practice that helps you to gather this information and build on it, so that the next encounter with a different situation is performed better, performed with more smoothly, performed with more confidence within the team members. So this is where the debriefs come in. It's a tool used to continuously improve the process by gathering information from the team members after each encounter. So after the encounter, you will check for
items like communication. Was the communication clear or not? Did you have any misunderstandings between the team members? The rules and responsibilities are clear or not? Did you have a situation awareness shared between the team members or not? Was the workload distributed in a way that helped every one of the team members perform the roles safely or not? Did we ask for or offer assistance between the team members or not? Because if we're not, again, offering assistance, this means we have a problem that we need to resolve. Were there any errors performed or not, which we can avoid next time? You can check what went well, what should change, and what can be improved for the next situation you encounter. So this is, again, this is our final video for this session, and we will show you how a debrief is implemented.
Great job, everyone. Can we discuss how things went today with Mrs. Keys? What did we do well, and what can we do better next time?
It was helpful for me to be brought in early. That allowed me to use a regional instead of a general anesthesia.
You're right, Brad. Lynn, what did you think?
It was great that Dr. Dean helped put the Foley in place while I did the count with Alicia.
Albert, this is a great example of task assistance. How was our communication today?
Excellent.
So, again, collecting the lessons learned, and most importantly, because most teams fall in this pitfall. Some teams use debriefs for learning from mistakes only. It's not only for learning from mistakes, it's also for reinforcing good behavior. So as you have seen, they showed some sort of task assistance, and the leader used this great example to reinforce the task assistance between the team members and how it's a required behavior between team members. So briefs used for sharing the plan, debriefs, huddles, sorry, for monitoring and modifying the plan, and for lessons learned and for reviewing the team's performance, you use the debriefs. Okay, so throughout the entire process, from start to end, conflicts may arise because these team members are all human at the end. And sometimes there are different perspectives between team members, different considerations that may lead to a rise of conflict. One of the most important rules of leaders is to resolve these conflicts as soon as possible. Okay, so resolving these conflicts ensures that the team members stay focused. They're not defocused by the interpersonal communication issues or the other considerations between team members. So this is one of the very important traits that leaders should demonstrate during the handling of the situation. So effective leaders facilitate conflict resolution to avoid compromising patient safety and quality of care. They do not allow interpersonal or irrelevant issues to negatively affect the team. They help the team members master conflict resolution techniques. They also promote and model the good traits they want in the team work between the team members by opening sharing of information, by role modeling and giving constructive and timely feedback to the team members, receiving even feedback on their own performance, facilitation of briefs, huddles, debriefs, and conflict resolution, and the mitigation of conflict within the team members. So this is the end of our first session on leading teams. So now we have learned about communication, the S-bar, call-out, check-back, and hand-off with Dr. Mohammed Al-Tawansi. We also learned about 3 new tools in leading teams, the briefs, the huddles, and debriefs. And now we'll be moving on to the second session. But before going to the second session, I'd like to check if you have any questions regarding the first one. Was everything clear? Do you need anything to be clarified more? All good. Okay, very good. So heading to our second session, situation monitoring. And I believe we have some sort of given hints about situation monitoring. Again, today in this session, we will give you a more in-depth look into its structure so that we can achieve it easily in our healthcare institutes. So our objectives for this session is to discuss how situation monitoring affects team processes and outcomes, list the components of the STEP mnemonic, explain situation awareness and identify undermining conditions, define a shared mental model and how it is cultivated within a team. So for our fourth component of the TeamSTEPPS structure, after discussing communication leadership, now for situation monitoring. Situation monitoring is an individual skill in which you monitor a certain aspects of the situation at hand and share this with others. So it starts with situation monitoring. You gain understanding to achieve situational awareness. You communicate this so that you have a shared mental model with this team. And of course, it's a continuous process because at any situation of hand, you have a lot of changes going on, a lot of progress that is happening to your cases. And this mandates a continuous situation monitoring from each team member. The STEP mnemonic consists of the status of the patient, the team members, the environment, the progress toward goal. So STEP, S for status, team for team members, environment, and progress toward goal. So in your opinion, who is responsible for monitoring all these elements? Use the chat, please. Is it the doctor, the nurse, the assistant? Who's responsible for this? Is it the patient? Team leader, very good. All leaders, very good. Okay, you're close, but you have to give it a little bit of more effort. Okay, so all team members are responsible to monitor this situation. Exactly, the whole team. We have a winner here. Okay, so the whole team is required to monitor all these aspects of the situation. We'll give you an example here. The respiratory therapist notes that a ventilated patient is showing a marked increase in a respiratory rate that might indicate an increased level of pain that cannot be communicated. So this is the status of the patient. Okay, the patient's nurse is busy helping another patient. Okay, so this is the situation in which the team member is. The nurse is busy. It is a shift change and everyone is busy, so you check the medication record and note that the patient is overdue for his morphine. Okay, so this is the environmental situation around you. So you notify the oncoming nurse of your concern, and this is the progress toward goal. So you go from checking the status of the patient, checking the team member situation, environmental conditions, and then you choose to progress toward the goal. So STEP, S-T-E-P, STEP mnemonic. Okay. Situation monitoring is a process of actively scanning behaviors and actions to assess elements of the situation or the environment. It enables team members to identify the potential issues or minor deviations, and it is beneficial in fostering a mutual respect and team accountability, providing safety net for the team and the patient, and includes cross-monitoring between the team members. Okay, So examples of the status of the patient, of the items of the status of the patient that you need to monitor is, for example, the patient history, vital signs, the medications, the physical exam, plan of care, the psychological condition, and any changes happening to any of these items that occur during the patient care. For the team members, fatigue, workload, the task performance level, the skill level of the team members, the stress level. And to facilitate this, there is a very beneficial tool. It's called the I'm Safe checklist. The I'm Safe checklist is used for cross-monitoring. And here, cross-monitoring between team members is sometimes taken as in a misconcept of spying on your team members. And here, you're not spying at all. You're just trying to recognize any risks that the team members might be facing, or the risks that the team members may be imposing on the situation itself. Because if the team member cannot perform the role properly, they may impose themselves a risk to the final outcome of the situation. So the tool here is the I'm Safe checklist. It stands for I stands for illness, M for medication, S for stress, A for alcohol and drugs, F for fatigue, E for eating and elimination. So these are the items that you should check for yourself and for your team members. For example, if they are handling a crisis situation, prolonged crisis situation, and they are overstressed by this situation, they cannot handle this properly, they cannot perform the roles accurately. So this is one item to check. If one of the team members is ill and this illness is affecting their judgment, they cannot concentrate, they cannot perform appropriately, again, one item to put in your checklist. Is this team member on medications, again, affecting their judgment or clouding their decision-making capacity? One of the checklists. Are they fatigued? Did they have a chance to get a snack or to go to the washroom or not? All these are stresses that must be monitored within the team members by all team members. You check it for yourself and you check it for the rest of your team members to ensure that all are performing appropriately and in a appropriate level of performance. Moving to our third component of the STEP mnemonic, the environment. Okay, so is the environment around the patient safe or not? Is there any issues related to equipment, to the facility itself, to any administrative issues affecting the patient care or not? This is the environment in which you're managing the situation or managing the case at hand. And finally, going to progress toward the goal, calling for a huddle, checking the status of the team's patients, the goal of the team, making sure that everyone is focused on the goal and performing towards the same goal, and checking if the plan is still appropriate to the changes that occurred during managing the situation or not. Okay, so can anyone name the STEP mnemonic, what it stands for? The S, for example. Okay, of course, you're not required to memorize it, but again, to build the structure, very good. Status of the patient, excellent. We have some very good, excellent. The status of the patient. What about the P? The P. Okay, excellent, excellent. So everyone seems to be on board and following. So you're again not supposed to. The outcome of this session is not to memorize this STEP mnemonic. It's again for building mental structures so that you can implement this easily every time. It's exactly like learning how to drive, okay? Especially for our new drivers, the females, okay? So first of all, you start by performing by the rules, turning on the ignition, changing the gear, pressing on the pedals. You go through step-by-step process in order to move the car, okay? But one time after another, you get more proficient in these actions until you start driving with your with ease and smoothly without thinking about the steps itself. So at first, you will find that you need to go through a structured process. If you implement it several times in your workplace or in managing a situation, you will be able to implement this more easily in the future situations. So in the picture you see in front of you, so does this show you a situation in which the team member is aware of the situation? Of course not, okay? So he's focused on one item of the environment. He's not focusing on the rest, what's happening, the bigger picture around him, okay? So the situation awareness is the state of knowing the current conditions affecting one's work, including all aspects, the status of the patient, the status of other team members, the environmental conditions, the current progress toward goal, all items should be checked. Unfortunately, there are some conditions that might undermine situation awareness, which is failure to share information within team members, failure to request information because you fear the criticism or for any other reason, failure to direct information to the specific team members that need to know this information, failure to include patient or family in communication, failure to utilize resources fully, failure to maintain documentation, failure to know and understand where to focus attention, failure to know and understand the plan, failure to inform team member, all are situations that greatly affect achieving this situation awareness and this shared mindset within the team members. Some examples for each of the step mnemonic components. For example, for the status of the patient, failure to take patient's vital signs. For the team monitoring, failure to assist a team member who you know is overloaded. In the environment, failure to know where the necessary equipment is stored. In the progress toward goal, failure to call a huddle and update the team member when the plan has changed. So all these situations undermine this process and decreases its effectiveness and decreases the whole team's effectiveness in managing a crisis situation. A shared mental model is a understanding between the team members that is consistent. It is the perception of the understanding of or the knowledge about a situation or process that is shared among team members through communication. So in the picture in front of you, does this show you a shared mental model between the team members, and why, please? Okay, use the chat. Okay, very good. So no, doesn't seem like it. Okay, yes, very good. Can anyone tell us why? Most of you, okay, are you agree all that this doesn't show you a shared mental model? Leader, okay, very good. Not supporting the team. One of the members is not engaged with the team. Very good. Everyone's working separately. Very good. Very good. Okay. Can you notice anything related to how the member on the right? I'm not sure if he's a leader or not. Is he dressed properly for the situation? One member is on vacation mode. Yes, exactly. So everyone seems like wearing some sort of hazmat dress. They're wearing breathing masks. and oxygen tanks. It seems that they are dealing with something very dangerous, and one of the team members is on vacation mode. Exactly. Okay. Yes, exactly. So yes, not involved also. Yes, very good. So this is one situation, and it's clear that one of the team members is not in proper understanding of what is going on, and is not dressed properly for the situation. This is another example, and it's one of many prolonged exercises. Go through it very quickly, just to show you that gaining all information related to a patient is very important in understanding and prioritizing your work. So these are three patients: Jackson, Simmons, and Bailey, and these are information related to each one. These are the orders requested for them. This is the heart rate, respiratory rate, and blood pressure readings. Take your time in reading the information. Okay, done. Everyone done? Can I go to the next slide? Yes, Dr. Asma Haggag, he came for the photo only. Exactly. Exactly. Okay. Can I move on to the second slide? Did you take a good grasp of the information? Okay, very good. Going on to the second set of information. Patient Jackson is a 23-year-old male. Patient Simmons is a 19-year-old female. Patient Bailey is a 76-year-old male. Again, this is a second set of information. Okay, now you're required to prioritize your patients. Who will you manage first? Jackson, Simmons, or Bailey? Okay, can you give us some sort of Bailey? Okay, very good. Who else? Second, third? Need more information. Yes, exactly. You need more information. But with only this information available, you will have a clouded decision, right? Do you agree? Very good. A lot of participants here agree on Bailey. Okay, so yes, so you agree that you need more information. Having this second set of information, patient Jackson is a known cocaine user with chest pain, and you are concerned about a possible myocardial infarction. Patient Simmons is hypotensive and experiencing tachycardia, and you are concerned about a ruptured ectopic pregnancy. Patient Bailey has tachypnea, tachycardia, and fever, and you are concerned about pneumonia. Okay, so what do you think now? Okay, yes, a very, very different perspective. Now that you have all the information, would you prioritize them differently? Yes or no? Yes, yes, I know. Yes, very good. So, yes, once you have all the information you need, your judgment will surely be modified according to the information available. So, keeping some information and failing to share this information will lead to a different understanding between the team members. And this is one of the most important and one of the critical aspects of managing teams, ensuring that everyone has a clear understanding of the situation, all information needed is distributed, and all team members are going to achieve the same goal. Yes, we gain more information, the picture will be more clear, and we can... Excellent, excellent, very good. Okay. This is one of the great examples here of having this shared mental model. So can anyone tell me what can you see in the first picture? The first one, the one on the left. What do you see in this picture? Okay, the one on the left, excuse me, the one on the left, not the one on the right. The one on the left. Under the question, exactly. So, okay, so someone says a person with a jacket. Okay. Side face of a man. See, the same picture is seen differently between team members. You all participated in the same activity. Some might see it as someone wearing like an Eskimo wearing a very heavy jacket. Another would see it like a side portrait of a man, of an Indian, exactly. The picture in the middle, some people might see it as a duck, some might see it as a rabbit. The one on the right, some see it as an old woman, and surprisingly, some see it as a very young lady. Okay, so these are the same pictures. Okay, these are the same situations. Okay, a lot of agree that it's a young lady. Okay, but it can be seen as both. You can see also a side portrait of an old woman. You can see here, this is the nose, this might be the mouth, and this is the chin, if you can see. Okay. Okay, sorry. Thank you for this, Dr. Ahmed. As you can see, some might see that this is the eyes, the nose, and the chin of a young lady. This is the ears, and this is her hair. While others might see that this is a long nose of an old woman, this is her mouth, and this is her chin. Okay, so everyone in the same situation might see what's happening in the environment around them in a different way. Having this shared mental model is critical for team performance. You will never be able to control this without having good communication and trying to prevent all factors that might undermine the performance of teams in handling a situation. So shared mental models help teams to lead yes, exactly. It's all about perspective. Yes, exactly. So it helps team to lead to mutual understanding of the situation, lead to more effective communication, enable backup behaviors, help ensure understanding of each other's roles and how they interplay, enable better prediction and anticipation of team needs, and create commonality of effort and purpose. So now you can see how situation monitoring, which is an individual skill, has an outcome of situation awareness, and with communication, it leads to a shared mental model within the team. This is our second session, the situation monitoring. We have learned about two more tools, the step mnemonic and the I'm safe checklist, and how to implement this in different situations. So can you see now how this skills and how these tools are interplay and are connected and help to serve in providing better and safer care and more effective care to your patients? Okay, do you agree that it helps you or not? Okay, can you rate it on a 1 to 10 scale? Strongly agree. Okay, very good. Yeah, okay, very good. So it was a real pleasure being excellent. Okay, very good. So it was a real pleasure having this opportunity to share with you this presentations, and it was a pleasure joining the Saudi Patient Safety Center again in its continuous efforts to improve patient safety and improve care in healthcare institutes. Pleasure to join Dr. Khalid, Dr. Ahmed Sheikh, Dr. Tawansi, our great team in this presentation, and we are always here to support any of you if you need any support in any aspect. Thank you all, and it was a real pleasure. Thank you.
Okay, hello everyone. How are you doing right now? We've been talking about more than 2 hours effectively, and hopefully that you enjoyed the sessions so far. I see very good commitment from your side. We are never less than 250 participants, which is really a positive point, especially that the CMEs are not there. So I was expecting that some people are going to leave, but mashallah, you're here and you're ready to learn. And we are here and we will do our best and utmost to give you information from the theoretical part, which is really very well built by the HRQ and which was excellently executed all across the globe, not only here, not only in Security Force Hospital Mecca, but we're glad that we had the chance to implement it in several areas, as exactly as Dr. Khalid mentioned in his introduction to this presentation, and as well our team, great team, Dr. Tawansi and Dr. Imam, just like what they did. Okay, so far we are almost reaching the final milestone of the presentation, and inshallah I'm going to take you to the final piece. So my great pleasure to be with you to present the mutual support. Okay, so let me reshare. Okay, moving our journey to the mutual support. After what we've learned today from the leadership, communication, situation monitoring, now it's time to make sure that the team is really a team. After what we learned with Dr. Imam about the dependency of information in order to prioritize the situations, now it's time to do a mutual support. This is the medium of communication, and there is a very good statement that describes mutual support, that it should be the norm that uprises team performance in every single location, and specifically in healthcare, as what we see right now. This is not a separate exercise. It really depends on the leadership, the communication, the situation monitoring. If you pave the way correctly on these blocks, the fundamental blocks, you will gain the fruit from the mutual support. Okay, so how can mutual support be implemented? First of all, it involves members. So here we back each other. We have state says that you should support your colleague either if he is doing right or he's doing wrong. So how can we do this support? It is easy to support them when they do the correct things. How can we support them? And specifically, as we define the team is is mixed between seniors and juniors, between different positions, different levels. How can we provide this support without jeopardizing the respect between the team, without breaking the team mutual work together, and so on? So they should learn, your team should learn assisting each other, the task assistant, providing and receiving feedback, asserting or assertive and advocacy behavior when patient safety is threatened. So what type of behavior do you think constitute mutual support? Here are 4 types. Monitoring other team members' performance to anticipate assistance requests, offering or requesting assistance, filling in for a member who cannot perform a task, providing encouragement. Which one represents mutual support from your point of view? Use the chat. Which one? Okay, so most of you got the trick. All of these. It depends on the situation, whether I'm going to monitor the performance to anticipate the assistant request, or am I going to offer or request assistance, or if a colleague cannot perform a task, I will back up or provide encouragement in order for them to do, or I'm going to step in because we are one team. The first skill that we should learn in order to perform a true mutual support is the task assistance. When the team foster a climate in which it is expected that the assistant will be actively offered as a method for reducing the occurrence of errors. So here, I'm not only passively waiting for requests for support, then I will say, excuse me, I'm fully loaded of tasks. I wish I could, but I cannot. Here, this team, if you're aiming for a team that really fosters a patient safety, this team shall be actively offering the help, offering the task assistance without any hesitation for their colleagues. This is backed up with feedback. And feedback is an art. It is not only words stated. Feedback is an art in terms of timing. Feedback is an art in terms of wording. Feedback is an art in terms of how do you provide it. So feedback are the information provided for the purpose of improving team performance. It's giving, seeking, receiving of performance-related information among a team member. So it's super important that this feedback shall be in place. Unfortunately, the most common mistake in feedback is not providing a feedback. So the most common mistake in feedback is not providing a feedback. So we should learn to provide feedback, and we should learn to provide feedback correctly. There are 2 types of feedback, formal and informal feedback. The formal feedback is what you usually get in discussions, case conferences, individual performance review, the annual evaluation, especially that we are in December. So this is the formal feedback. When you sit with your manager, with your leader, and he or she, based on criteria, hopefully provides you with the feedback. So it is typically retrospective, typically scheduled in advance, and typically has an evaluative quality. But the informal feedback, it's usually real time, it's bedside. Thank you, good job. Can you repeat it? May I ask you if this is the right way to do? And so on. This is provided on an ongoing basis. It's not documented, most probably. It's instant. It's on the fly. It focuses on knowledge and practical skills development, just like some examples that we mentioned, the huddles and the debriefs. But again, it's an art. There are characteristics that make effective feedback. Effective feedback shall be timely, it should be respectively, it should be specific, directed toward improvement, helps prevent the same problem from occurring in the future, and considerate. So if you provide the feedback after a couple of days, it's not there. That's why, by the way, we insist as quality people that OVRs shall be reported timely as much as you can, because OVR, believe it or not, it's type of feedback. Yes, it's a little bit, or to a great extent, it's formal, but by the end of the day, it's very important to be timely, because if I can intervene with the case and improve the patient outcome, why should I wait for 7 days until you submit your OVR and the patient is already at home? Or unfortunately, maybe the patient is shifted from the ward to the ICU, or maybe far away. Respectfully, despite what you ever have a feedback, this feedback shall be respectful. Even if there is a mistake, no, especially if there is a mistake, you should respect your colleague. By end of the day, you are colleagues. Both of you are coming from home, driving to the hospital, wearing your dress code in order to help these patients. You're not here to kill, you're not here to make mistakes. So it is with all due respect. But we will learn today how to make an assertive, respectable feedback. It should be very specific, not vague, not cumulative, not based on years and months and weeks of mistakes, minor mistakes, which took the ice ball route in order to be something very huge, and suddenly, boom, explode in front of all colleagues and patients. It should be very specific. Oh, thank you so much, NM. He says that avoid criticism with feedback. It's a positive, it's constructive feedback. And this is the point that we're coming to, number 4, directed towards improvement. It helps prevent the same problem from occurring in the future. So it is a preventive nature. Even if the mistake already took place, yes, definitely. Make sure that you prevent it the next time. This is your role here, and this is how you back and mutually support your colleague. So feedback is where the learning occurs. Let's check a very brief video about the feedback.
Greg, I'm Carrie Feldman, Mrs. Everett's daughter. Hi, I just wanted to say you did a great job with the heads up on Ms. Everett the other night. Amy said she might not have realized Edna was getting so sick if you hadn't spoken up.
Sure thing, thanks.
Amy mentioned there's a nurse managers meeting next week. I thought what you did would be a great example of effective communication and teamwork to spread across our units here. Would you mind talking to the group about what you did?
Not at all, Dr. Feldman.
Okay, so we will get back to this video. It's very important. And really here, the feedback was very nice from the physician to a nursing assistant, okay, who discovered something a little bit weird about a patient, and he conveyed the message very well to the physician, and they discovered that the patient was deteriorating. So very important takeaway here is that you should make sure that all team is real team. All of them feel that they are part of the patient care. So your cleaner can give you very valuable information. Just open the door. Your nurse aide, your ward clerk, all of them are very important and vital and can give you really important, crucial information that may help you to support the patient care in your facility. The third point, which is more important, advocacy and assertion. You should be advocate for the patient. I'd like to build here on the point of criticism. We are here for the patient. We are advocates. So if we are providing a true patient-centered approach toward our patient, so this means that all these feedback are going toward the patient. However, this should be provided in a firm yet respectful manner, because again, some of these errors may lead to patient life or death. So you should be very assertive. Your message shall be very clear. You should not be hesitant because you are an advocate for the patient. So the assertive statement, it should be respectful and supportive. It should clearly assert concerns and suggestions. It should never, whether it is from bottom up or from top down, it should never be threatening. It should ensure that the critical information is addressed. You have 5 process steps to deliver an assertive statement, or at least this is what the AHRQ is advising you to do. First of all, open the discussion. State clearly your concern, state the problem, offer a solution, and obtain an agreement. So I'd like to discuss with you XYZ. I am concerned of ABC. The problem here that it may lead to EFG. I think that the best way to do it is ABC. Do we agree? This is how you can very easily gain an agreement with your colleague. Make sure that when you state the problem is real and clear. Make sure that when you offer the solution is toward the patient. It's system focused, not person focused. So a solution of, I recommend that you should be replaced or fired. This is not a solution, despite the fact that this may be real, but this is not the way that you can address it. It should be addressed in a different scenario, okay? And finally, you should obtain an agreement. So for these 5 steps, is it clear? Can you implement it today and tomorrow? Yes, no. Use the chat, please. Clear? Yes, no. Okay. It might take time to develop the culture. I will vote with you on your feedback, unknown user. So yes, it will take time. It will take time to be adopted. It will take time to be accepted. But by end of the day, it should be the norm. What if? So what if there is a challenge between the team? What should we do? How can we handle challenges? We're not in utopia, with all my due respect. So we will never ever reach an agreement every single time. No, big no. Sometimes we are going to have some conflicts. It's not the ultimate goal to eliminate these conflicts, but the ultimate goal is to get the best out of these conflicts. And usually they say that conflicts are healthy in teams, but we should complete the statement that if utilized well. So the 2 challenge rule, when an initial assertion is ignored. So you stated, you used the assertive, you provided that you made your part in the first situation. So you provided your feedback, but what if this was ignored? It's your responsibility to assertively voice your concern at least 2 times to ensure that it has been heard. The member being challenged must acknowledge, and if the outcome is still not acceptable, take a stronger course of action or chain of command. So you should here state your, I will give you another tool right now. You should definitely use another tool in order to make sure that your concern is clearly heard. You should make sure that every time it's your responsibility to deliver this concern. And the member challenged shall acknowledge that yes, we should do X, or no, we should do Y. If the outcome is still not acceptable, you should take stronger action. How can we do this? Two tools. The first one is the CUS words, but only when appropriate. CUS stands for I am concerned, I'm uncomfortable, this is a safety issue. I am concerned that this dose is higher. I'm uncomfortable with this decision, and I state that this is a safety issue. We will see the example after a while. After we take the strongest path or the hardest one, what if there is a real conflict in the team? So if informational conflict, we have different information. Either we go with the two challenge rule, the CUS rule, or we do a desk script. But if this is an interpersonal conflict that requires an immediate intervention, there should be a desk script. What's the desk script? You should describe the situation, express your concerns, suggest other alternatives, then consequences shall be stated. So either that I CUS or I desk it. So when you desk it, you describe the situation, express your concerns, suggest other alternatives, and consequences shall be stated. Let me show you very short videos about this. Give me 1 second.
When something doesn't seem right, do you feel comfortable speaking up? Maybe you're afraid of offending someone by pointing out a mistake or conflicting information. But when safety's on the line, it's important to voice your concerns. CUS is a tool that helps anyone speak up without challenging someone's authority or professionalism. Use this tool as an escalation. Start by expressing your concern, and if that doesn't work, continue on with the remaining steps. Here's how the escalation works step by step. C. State that you're concerned. Be sure to provide a reason for your concern to give the other person the opportunity to provide an explanation that could resolve the issue. U. If that doesn't stop the action, escalate by explaining that you're uncomfortable with the situation. S. If things don't change, emphasize that this is a safety issue and that you need to stop the line. These are key words that should make everyone stop and reflect. It's easy to get defensive when your actions are questioned, but it's nothing personal. CUS is a structure we should all follow to keep patients safe. When everyone understands these key words, it can help these potentially inflammatory situations feel less personal and more integrated with workplace culture. Patients and families should also be empowered to speak up and raise concerns about their care using CUS. Teach your patients and families the CUS tool, but instead of saying, "This is a safety issue," change it to, "I'm scared." Remember, you have a responsibility to state your concern at least twice when you notice something wrong. CUS can empower you to speak up with confidence. Miss Newton is an 82-year-old patient who's been chatty and animated since being admitted 2 days ago with a blood clot. Craig, a dietary aide, notices that something's not right, and he decides to discuss it with her nurse.
You wanted to talk to me about Miss Newton?
Yeah, I'm concerned about a change in her behavior.
She seemed in good spirits, but when I talked to her just now, she seemed disoriented, not like herself.
Well, I checked her vitals about an hour ago. She was napping, but she seemed fine.
I feel uncomfortable leaving her like this. I'd feel better if you'd go see her.
Well, when you put it that way, that does sound concerning. I'll go check on her. Thanks, Craig.
Let's recap what went well in this situation. Craig felt empowered to speak up despite not having a clinical background. At no point did he question Brenda's professional judgment or her ability to do her job. He used the keywords, specifically saying that he was concerned. By the time he said he was uncomfortable, Brenda recognized the cuss language and knew to pay attention. You can feel empowered to use cuss in any situation where patient safety is threatened, no matter who you are or who you're talking to, and even if it hasn't gone so well in the past.
Okay, so I believe this made it very easy and very handy to use. So the good thing, by the way, is it should be by time like a code. So once you hear the word that I'm concerned, you should pay attention that there's something. Uncomfortable, it's escalating. So I should be there and I should be ready for the next step. So what if I'm going to disk it? I'm going to escalate. Now let's see.
Even if you get along with your colleagues, chances are you won't see eye to eye 100% of the time. Workplace conflicts happen, and in a healthcare setting, a tense environment or unresolved dispute could weaken communication and impact patient care. When you need to de-escalate a situation, sort out a misunderstanding, or point out where things could improve, you can use the de-esc tool to prepare for what could be a difficult interpersonal conversation. Whereas cuss is a tool for immediate patient safety issues, de-esc is reserved for resolving interpersonal differences. D, describe the situation. E, express your concerns. Do this privately so the other person doesn't feel embarrassed or called out in front of others. S, suggest alternatives to what's happening. C, state the consequences of the situation as it stands. This isn't about attacking the person, but about making things better for everyone. Remember to prepare and think through what you're going to say and how they might respond. Try to set aside any resentments and keep it focused on finding a solution.
Okay, let's see it in action.
At the front desk, Lindsay has developed a habit of gossiping about the doctors and other staff with coworkers. It's bothering her coworker Karina, especially since patients can hear. She wants to bring it up with Lindsay, but she wants to get it right.
Hey, Lindsay, can we talk? Is now a good time?
Yeah, what's up?
So I've been thinking about this a lot, and I felt like I had to say something. I noticed that you sometimes vent about the doctors when we're at the front desk.
So what? It's healthy to vent. That's what I always say.
I'm just worried about the kind of environment that creates. I know it feels good to gossip about work, but it would be best if that happens in the break room or somewhere out of earshot of the patients. When patients hear you say something about any of us, it may make them feel less confident about the staff and the care they're getting here. You know what I mean?
Yeah, I guess if I were a patient, I wouldn't want to hear that stuff about my doctor or the staff.
Let's go over what Karina did well. She was prepared for the conversation and pulled Lindsay aside in private. Karina used I statements that make suggestions about how things could change. She focused the conversation on having a more enjoyable workplace while also keeping the best interests of the patients in mind.
Okay, now we see how we can describe the situation. She expressed her concerns very clearly, suggested alternatives, and finally stated the consequences. If the care is going to continue this way, what are we going to face? Very important points to pay attention before we close talking about the desk. The discussion shall be timely. It should be focusing on win-win. You should frame the problem in terms of your own experience. Use the I, use the we. Do not make things generalized or just being escalated. Choose a private location. 50% of the success is the private location. Whenever you confront people in front of others, you are going most probably to lose the desk at this time. Use I statement. Avoid any blaming statements. Critique is not criticism. So I'm focusing on the system rather than focusing on you. And I'm focusing on what is right, not who is right. I hope this is clear. Is it clear? Before we move to our final part, pulling it all together. So out of 5, if 5 is clear, understandable, you can implement it tomorrow, and 1 is totally unclear, can you provide us feedback? Because we said that feedback is important today. Okay, thank you so much. Let's put it all together. How can we utilize this? By the way, in the field, these are going to be snaps. You will not have that so much time. Okay, I'm going to use the diskette, I'm going to use the CAS, I'm going to use this. Is going to be just like a normal conversation. It will look like this, but there is a lot of effort that was done to the mindset in order to reach the TeamSTEPPS mindset. So all this is blended together. So you should have, you should shape your leadership correctly. The communication should be there, situation monitoring in place, and mutual support. If you have all this in place, it should be using several tools, starting from what you should understand, what are the barriers, what are the tools and the strategies that we went through. Accordingly, you're going to get with the outcomes, the shared mental model, the adaptability, the team orientation, the mutual trust, the performance, and the patient safety. Now, I will see the video. I will pause it several times. We will see before and after of a case that took place and maybe taking place in your hospital or maybe mine, and how can we prevent it. Let's see. Let's start from here. This is a story of a lady that had a care in a hospital. As you see here, she is a 45 years old female, underwent thyroidectomy this morning, and her surgeon felt uncomfortable after the procedure since she was unable to visualize all the 4 parathyroids. Let's see.
Hey, Liza. Mrs. Peters still seems a bit groggy. I'm running up the floor to see our discharges. I'll be back in about 15 minutes. And she did well. She should be able to go home by Friday. I want to keep an eye on her calcium. Will she be going to the floor soon?
Yes, I'm about to start report.
Great. If you need me, just page me.
Okay.
So she just mentioned that I'm a little bit worried about her. If you can page me, just if you need anything, page me. I'm a little bit worried. Okay.
Hi, Carla. This is Liza down in the recovery room. I'm calling about Dr. Daniel's patient, Miss Angie Peters. She is stable and ready to come up to the
So now she states that she is stable and she's ready to come to the floor. Any concerns?
floor. She just had a big goiter removed, and she's 54 years old. No major medical problems except for hypertension. Vitals are stable. Pain score is 2 out of 10. She has no drug allergies. Dr. Daniels, the attending, wants to keep an eye on her calcium.
So the final piece of information that was mentioned here, that Dr. Daniel would like to keep an eye on her calcium. Why? We don't know.
You know, she might be a teacher or something like that. Anyway, do you know which bed?
She might be a teacher or something.
That she's going to? She should be ready to go in about a half hour.
Believe it or not, the endorsement is done. That's it. If you are the one on the other side, are there any concerns that you got from this tone, from this voice, from this order of information? Let's see.
Well, your vital signs look good. Now, Andrea, your fingers feeling numb or tingling? Are you feeling any shortness of breath, any muscle cramps?
See this enlistment? I will repeat it again, okay?
Well, your vital signs look good. Now, Andrea, your fingers.
So, are your fingers numb or tingling? Are you feeling any shortness of breath or any muscle cramps? It looks something very usual. Nothing unusual here.
Feeling numb or tingling? Are you feeling any shortness of breath? Any muscle cramps?
No, I think everything's feeling fine.
Good. Now here's your call button. I want you to use this if you experience any numbness or tingling in your fingers, any shortness of breath, or any muscle cramps.
Again, repeating the same with the same tone, no explanations, no more information. This is my job. I'm doing my job, then I will walk away.
I will.
Okay, now you get some rest, okay?
Do you notice someone in the back? In the back of this scene, how many people are there? 2, 3. Maybe a family person, maybe a relative, someone who's supposed to have a role in the patient care, but she was ignored.
Calcium level Q, 12 hours. Huh, that's a little weird. She crossed out the residence order.
Okay, so the calcium level is Q, 12 hours. That's a little weird. She crossed out the residence order. I wonder why. Oh, well. So the problem here is that is a cross of the resident order. It's not the frequency is higher. Why the frequency is higher?
I wonder why. Oh, well. Billy, we need to get these orders in so the blood draw gets added to the afternoon room. Okay.
Okay, if you see the calcium here is 0.78.
My fingers feel all numb. It's my darn arthritis getting me all.
Oops. So the lady is starting to feel the numbness, but she thinks that this is due to her arthritis.
Cramped.
Mom, shouldn't the pain medicine be treating that?
And her daughter, which seems to be really interested, says that, may I call the pain management team for you?
Do you want me to call the nurse?
It's not that bad. Anyway, I'm here from my neck, not from my arthritis.
Exactly. I like this scene. So the lady is there. She understands that there is something strange, but she says that I'm here for my neck, not for my arthritis.
Well, if you're sure, I'll be fine. And you need to get on home. Just give a big kiss to my little angel from Grandma.
Okay, Mom, you get some rest. I'll be back in the morning. Okay, here's the call button. You make sure you wait for help if you need to go to the bathroom. The last thing we need is for you to fall.
So her daughter is more concerned about the fall, which is a risk, but it is an unforeseen risk right now. She was not concerned about the numbness. She was the one ignored. She didn't know that this is a higher risk rather than the fall on her mother. And this is the result of all what we see.
I'm Linda Reese. What's going on with my mother, Angie Peters? Linda, your mom's having seizures. The doctors are getting her stabilized. They're going to have to insert a breathing tube, and she's going to be moved up to the ICU. We've called Dr. Daniels, and she's on her way up.
When did this happen? She was fine
I
when I
know.
left her last night. Why didn't someone call me?
It just happened.
Okay. This concludes everything in 3 words. It just happened. My question to you, do you think that it just happened? This lady is going to spend the next night in the ICU and maybe in the grave. Do you think that this just happened? What do you think? Write in the chat. No, it didn't just happen. It seemed like this was, I don't want to say intentional, but so the inputs led to the outputs. And this is what we have right now. It's a series of events led to this. No, she had post-operative issue. She ignored the warning signs. Unfortunately, this may be the best hospital ever, with the best physician ever, and a very keen relative, and an educated patient. Best equipment, best everything, but there is no teamwork. Okay, the good thing here is we have the other way around scenario. What if we implement TeamSTEPPS to this scenario? And the first thing that you will notice that the time of this video is double. Rather than 3 minutes, it's 7 minutes, because there are lots of things that is taking place here. Same lady, same setup. I'm going to pause again for you in order to make sure that you follow the video well, and let's comment on this based on the TeamSTEPPS.
Hey, Liza. It looks like Mrs. Peters is still a bit groggy. Will she be going to the floor soon? I have to get up to the unit.
Yes, I'm going to call report. She should be up in 15 minutes.
Okay. I've added some extra labs to her post-op orders. Mrs. Peters may have problems with a drop in her calcium. Her thyroid was just huge, tucked in way beneath the sternum. We didn't visualize all 4 parathyroid glands, and they might have been damaged.
Okay, I'll pause here. We didn't visualize all 4 parathyroid glands, and they might be damaged. She seems okay now, but I want her calcium level checked twice a day. This is the same twice a day that was stated just like that in the previous conversation. Now it's stated using 2 more seconds, but I'm conveying the concern.
She seems okay, but I want her calcium level checked twice a day. She'll need to be monitored for trouble breathing, muscle cramping, and numbness and tingling in her fingers.
Okay, I'll make sure to pass on a report to watch out for hypocalcemia.
A clear feedback. Okay, I'll make sure to pass on in report to watch out for hypocalcemia. Clear statement, clear question. Did I get you right?
Okay, excellent. If you need me, page me.
Okay.
If you need anything, just page me. Sometimes we just miss this. I told you, you do the rest. No, if you need anything, just page me. Let's check the endorsement.
Hi, Carla. This is Liza Colby, one of the RNs down in recovery room.
So first of all, she asks her, ready for report on Dr. Daniel's patient, Miss Angie Peters. I have a concern here that they identified the patient with 2 names. Forget about this. Let's focus on the video. Okay. So, but at least she established the stage. She asked her, are you ready for the report? She may say, okay, can you give me a couple of minutes? I will be back with you, in order to make sure that she's ready to get
Ready for report on Dr. Daniel's patient, Mrs. Angie Peters? Angie Peters, 54 years old, going to room 416, bed 2 on 4 East. Status post total thyroidectomy this morning. Doing well now. BP 120/85, heart rate 80, temperature 37 degrees.
This part is what is a classical nurse is going to do. She's going to endorse the vital signs, the patient data very well. The issue is how we start, how we finish, what we focus on. Okay. And thanks for, again, for NM. I wish that I knew your name. It's the previous one was a clear example of a Swiss cheese model. Yes. Suppose I assume, a non-user, I assume that she documented this in the patient order.
Celsius, O2 is up to 97% on 2 liters, and pain is 2 out of 10. Surgery was remarkable for a large thyroid, no pre-op issues. She's a Jehovah's Witness.
You remember, she's a teacher, but she's Jehovah's Witness. And if you're familiar with this, those people do not accept receiving blood. This is something relevant. Previously, it was not.
So no blood products, but she is a full code. Her advanced directives are in the front of the chart. We have one safety concern, hypocalcemia.
Okay, now pause. We have one safety concern, hypocalcemia. Do you hear me? Do you get it? I have something important. I'm putting the brackets here. Listen, please.
Dr. Daniels, the attending, ordered calcium levels Q12 hours because she's worried about possible hypocalcemia. So monitor pins and needles, muscle cramps, and shortness of breath. You'll need.
This is the same nurse that was asking why she crossed the resident order. Now she knows what is going there.
To review these symptoms when she's fully awake. Normal saline IV is running at 100 cc's per hour. Meds are metoprolol, 50 milligram prior to surgery, and we just gave her 4 milligrams of morphine. Urine output is good. Police to be DC'd in the morning. I'll let transport team know to ask for you. That is Carla Lopez, right? What else can I tell you?
If there is something that you need your nurse, your team to learn, is to say this a lot. What else can I tell you? What else can I help you with? Okay, this opens the channel for communication and give people a pause to think, and if there is something they're going to do.
Yes, that's right. You've got all the information right.
You got all the information right? Anything else?
Good question. There are no known drugs.
Not only, yes, there is something missing. She didn't mention the drug allergy, but you see the feedback? Good question. Good question. She didn't wait until her appraisal to say that you're doing good. Good question.
Allergies.
Okay, Angie, I've got one more important thing to go over with you before we let you get some rest, okay? Have you noticed any numbness or tingling in your fingers, your toes, any cramping in your muscles or tightness around your throat since you've been out of surgery?
No.
So far, this is the same question, okay? Let's see how this can be TeamSTEPPS, if we can say.
Oh?
No? Okay. I'm asking you these questions because very rarely after thyroid surgery, your calcium level in your blood can drop.
Oh, is that serious?
It's easy.
Okay, the third person is here. She has a mouth and she can talk. She has some ears and lots of interest. She's going to be very beneficial
for us to fix, but we can't let it go. A low calcium level that isn't treated can cause serious problems.
Okay, I like how she delivered the information. So it's not that serious, but it should be monitored.
I see. Dr. Daniels asked me those questions in recovery, but I thought I was dreaming.
Mm-hmm. If you experience any of these symptoms at any time, let us know right away, okay?
Okay, but this is making me nervous.
Oh, I'm not trying to scare you. Dr. Daniels just wants to be safe. Low calcium levels are rare. They're easy to treat. We'll be checking your blood tests. If you have any symptoms, we'll contact Dr. Daniels immediately. We just want you to be aware of what we're looking out for so that you'll let us know, okay?
So simply, I'll take a few seconds back. Okay, so we just want you to be aware of what you're looking for so that you will let us know. Patient is fully engaged.
We just want you to be aware of what we're looking out for so that you'll let us know, okay?
Okay, so tightness in the throat, tingling, and what was the third?
Muscle cramps, right?
That's right. It's nice to have your daughter here to help keep an eye on you, right?
Mm-hmm.
Do either one of you have any questions?
I don't think so.
It's good to have your daughter here. Any questions?
No, I think we'll be okay for a while.
Okay. Now here's your call button. Get some rest, and I'll be back to check on you in a little bit, okay? All right. Hey, Miriam, you have rooms 12, 13, 15, and 16. Here are the rundown on your patients.
If you feel a little bit that there is a little bit odd, that there is another part of the video, this is because there is some good work to keep this patient alive.
We got Mrs. Peters, who's a 54-year-old woman. She's in room 128. Here's the chart.
Do you have Mr. Smith's most recent labs?
No, we don't. That's actually a great point for us to start today's brief.
So this is a good starting point for us to debrief. Please, we're going to make a brief.
Hi, everyone. Let's spend a minute talking about things for us to be aware of today on the unit. The lab's backed up with an analyzer down. We're doing urgents and stats only. We're at 80% occupancy and down 1 LPN. Janice will be picking up that coverage.
Who's backing up Janice?
I think you can handle that.
Oh, sure.
Except for that she gave her the responsibility because she asked it, I like the situation.
What's the ER status tonight?
We're back into Vert again. I think that's it. Anything else critical? Watch Mrs. Peters for possible hypocalcemia and Mr. Smith, who just started the beta blockers. Both are currently stable.
Got it. I'll check back on Mrs.
No, she didn't forget. She's telling back.
Peters' calcium levels and symptoms and monitor Mr. Smith for hypotension.
Perfect. Okay. All right. Thank you.
Can you please tell the nurse I'm having some cramping and some numbness in my fingers?
Mrs. Peters, this is Miriam. I'm right outside. I'll be in shortly to check on you.
Billy, can you check if we got Mrs. Peters' labs back from this afternoon?
Task assistance, I'm going to check the patient, you check the results, and I will call you from there.
Calcium was 0.78. Boy, that's right on the wire for a critical value. Let me see what her pre-op value was. Who's on the board for Dr. Daniels tonight?
Dr. Ashley George.
Thanks.
Hi, this is Dr. George. I'm taking care of Angie Peters, a post-op thyroid patient in room 416 on
There's a conversation between a physician and the pharmacist.
4E. She's been dropping calcium level pretty fast and she's showing symptoms too. We'll need to treat her, but she's not tolerating PO meds. Can you help me with the IV dosing?
If there is an exercise for you, you should discover here where is the S bar. A complete S bar in one statement.
Okay, you're going to need to write for 1 gram of calcium gluconate diluted in 100 milliliters of normal saline, IV for an hour.
Okay, so let me confirm that. 1 gram.
So I read back because this is a high alert medication.
Calcium gluconate diluted in 100 milliliters of normal saline IV over an hour?
Correct. IV calcium has to be a slow infusion. If it's given too fast, you risk vascular damage.
An explanation. We are one team and I'm providing the information, even if you know it, but I'm just making sure that you understand it and get it.
Okay, great, thanks.
It was treated successfully. She was discharged the
Hi, Carla.
next day. So hopefully that your patients are going to have the same way of treatment, the same way of real teamwork in order to improve their care. So out of 5 now, what do you think about these 2 videos? Did it conclude the whole 3 hours for you? Have you seen how the base is very fast? And these tools, never takes so much longer time or going to get delayed. You don't have time for this. Okay, I see lots of excellence. Thank you so much. Okay, by coming to this, I believe we can conclude and we will open the floor for you to write your questions and we are happy to answer. Yes, you need to give some more time for understanding. And please, when you do this training, please make sure that you blend the expertise of your teams very well. So do not bring the physicians, the nurses, the pharmacists, everyone in silo and so on. No, this is not the restaurant, because I'm quite sure if you do not implement team strategies well, go to your restaurants now, it's 1 p.m., go there, check the tables. You'll find that physicians are sitting with physicians, nurses are sitting with nurses, and so on. This is not the case for the TeamSTEPPS. Make sure that you blend them very well. Okay, any questions? Okay, I'd like just to highlight one final point here before we close. It's a journey of implementation. What we just mentioned right now are just the key highlights. Material is there, it's very, it's available, and some updated videos from all around the globe using these TeamSTEPPS strategies are there, including us and including lots of other more amazing work. So you should give more effort for the TeamSTEPPS and the team working skills, because this is really crucial. It's not only the technical part, the clinical part shall be equal important. It should be the team part. It's equal. It's equally, if not, that's going to be a barrier for your very excellent work to reach your patient and to have the best care for your team. Okay. No more questions? Okay, so overall, out of 5, From 1 to 5, how do you rate it? I believe you're going to get a feedback survey. We would love to hear your feedback. Okay, 10. Thank you so much. Okay. Indeed, we have a culture challenge, especially with nurses and physicians. Yes, don't ever think that this is something that you only face. It's everywhere. It's really everywhere. And how to overcome this? Make sure that you invest lots of time for the implementation of such strategies, not only for the clinical, technical, BLS, and so on trainings. There is a very important arm, which is the team arm, shall be there and shall be in place. Okay, thank you so much. We really enjoyed the day with you today. We would like to express our deep thanks for our colleagues in the Saudi Patient Safety Center. It's always a pleasure to have the cooperation with them as a very strong arm for improvement of the patient safety. A WHO collaborating center on patient safety policies and strategies, and indeed they drive the patient safety higher all across the kingdom, and regionally I can claim that this is all as well internationally. We have audiences from all around the globe, and inshallah later we can make more into depth workshops about this. It is really amazing to make it in person. We really love it, but we love the impact that it can provide through online. I'd like to thank my colleagues, Dr. Khalid Al-Zahrani, Dr. Muhammad Tawansi, and Dr. Muhammad Imam for their marvelous contribution today to the presentation. Have a nice day, and please start to implement after the session. It's an endless effort, and inshallah it's going to be paid off. Thank you so much. Thanks, Ms. Heba and Saudi Patient Safety Center team. Thank you.